All right, let's find orthopedics. It's time to do orthopedics, okay? And the first thing we're going to talk about are fractures. Now, with fractures, we have continuous pain, unnatural movement, and deformity. I mean, sometimes you can just look at somebody's foot, and if it's pointed backwards, you know it's broken, right? Right. It's pretty obvious many times. Now, shortening of the extremity can occur, and the reason we have shortening of the extremity is because of muscle spasm. Muscle spasm is what's causing the extremity to shorten, and then sometimes you can hear crepitus. Now, crepitus would be the bone ends grating together. The bone ends grating together. Now, swelling and discoloration, that scares me with fractures, because when you have swelling and discoloration with fractures, you have to worry about compartment syndrome. That's your number one concern with orthopedic injuries, would be compartment syndrome. Now, the reason that scares me so much is this. Can compartment syndrome cause me to lose my extremity? Yes, that's what we're so worried about. It can cause you to lose your extremity. All right, treatment. Well, first things first. We're going to immobilize the bone ends plus the adjacent joints. We support the fracture above and below the site and move the extremity as little as possible. All three of those things are just to prevent further injury. Prevent further injury. And splints. Splints help prevent fat emboli and muscle spasm. Fat emboli and muscle spasm. Now, what do you do with open fractures? If the bones are sticking out, what's one of the first things you need to do? Cover the area, preferably with something sterile, but we don't always have something sterile to cover the area with. Now, you go back into the room, and the bones that were once sticking out have disappeared. They've been pulled back down into the wound because of the muscle spasm. That's what's happened. Many times that happens. Now, the problem with that is infection, because when the bones were pulled back down, they could have introduced infection down into the muscle or the tissue as well. Now, the most important thing in the whole wide world to remember about orthopedics would be neurovascular checks. Notice, it's not just a neuro check and it's not just a vascular check. It's neurovascular. All right. Now, out of all of those things that you see there, your pulses, color, movement, sensation, capillary refill, and temp, which two are the neuro component? Ask your friend. The two that are neuro are movement and sensation. Movement and sensation. Now, on the first day of the class, we said that sensation could also be circulatory, okay? But remember that sensation, especially with an orthopedic injury, we're going to consider it to be a neuro component, but sensation can go either way. All right, now. Complications, shock. Well, you can bleed, can't you? It depends on the extent of the injury. And a fat embolus is always a biggie when we're studying fractures. Now, with what type of fractures do you see this? I bet everybody just said long bones, like your femur. Right. Long bones. That's very important. But since everybody already knows that one, we better learn some other ones too, such as pelvic fractures, and any crushing injury. Any crushing injury. And the symptoms depend on what? Where it goes. The symptoms depend on where it goes. Now, I've written down for you some weird symptoms you can see with a fat embolus, okay? And one of the weird ones that you can see that we really don't know why it happens is petechiae or a rash over the chest. Petechiae or a rash over the chest. So we need to be watching for that with those patients with long bone fractures or pelvic injuries, crushing injuries, that sort of thing. Another weird symptom that you may see, conjunctival hemorrhages. Now, that's just where they're bleeding into the conjunctiva. Now, they don't know why they have these symptoms that I've mentioned so far, but they're classic signs of a fat embolus. Another one you may see is called a snowstorm on the chest x-ray. A snowstorm on the chest x-ray. Now, I bet you've read chest x-ray reports before that said things like patchy infiltrates, or you've actually seen a chest x-ray where the lungs had white fluffy stuff on the x-ray film itself. That's all that a snowstorm is. They just call it a snowstorm on the chest x-ray. Well, a fat embolus likes to go to the lung, so we want to consider pulmonary symptoms too. Now, some other points that I want to make about a fat embolus would be this. The people that tend to get a fat emboli are young males, because young males tend to be risk takers, so their injuries are greater usually. And also, another fact, if you're going to get a fat embolus, you're probably going to get one within the first 36 hours after the injury. The first 36 hours after the injury, that's kind of like the danger time for a fat embolus. Now, don't get me wrong. A week or 2 weeks later, your patient could get a pulmonary embolus because they have thrown a clot, thrown a DVT. But in that early time after the injury, we're worried about a fat embolus. All right, now another big problem, compartment syndrome, and you've already heard me mention this once already. Now, this is when the fracture has not been elevated and has not had ice packs. Fluid accumulates in the tissue and impairs tissue perfusion. The muscle becomes swollen and hard, and the patient complains of severe pain that is not relieved with pain medicine. Now, notice I said it is severe pain that is not relieved with pain medicine. The pain is unpredictable, disproportionate to the injury, and if undetected may result in nerve damage and possible amputation. So that's why we have to watch this so closely. I've already asked you this question once. Can the patient lose their extremity? Yes. Now, common areas are the forearm or the quadricep. Forearm or quadricep. Now, you need to understand that you do not have to have a fracture to get a compartment syndrome. It's just that we always study compartment syndrome with fractures. There are times when you'll see patients who've injured themselves. Maybe they've had an insect bite or they've burned themselves. Those people can get compartment syndromes as well. We just always study this mainly in the orthopedic section. All right, well, what do? Loosen the cast to restore the circulation. You've got to loosen the cast to restore the circulation. We want to get that, relieve that pressure some way. Also, a more invasive procedure that may be done, depending on the severity of the compartment syndrome, is called a fasciotomy. Now, a fasciotomy is when the doctor is going to cut down into the tissue to relieve the pressure, to restore the circulation. That's right. Relieve the pressure, restore the circulation. That's the name of the game here. That's just a more invasive procedure. Now, be careful of the answer, remove the cast. For me to select the answer, remove the cast, they would have to have a really, really, really bad neurovascular check. I would have to feel, after I read the scenario in the test question, I would have to feel like I did not have any time left to call the doctor, that I needed to act fast to save that person's extremity. Okay, so I'm not saying remove the cast would never be the right answer. I'm saying that if they have a really bad neurovascular check, like their hand's purple, it's numb, you don't feel the pulse, and they've got a forearm cast, and that's the only thing I can do to save their arm, then I'm going to do that. But if I have any time left to work with, I'm going to call the doctor before I remove the cast, okay? I would rather it say loosen the cast. That'll always be my favorite answer, because you're still leaving the cast in place. Loosen the cast. Now, you may say, well, how do you remove or how do you loosen a cast? Well, orthopedic nurses have cast cutters available to loosen the cast, okay? And you need to be sure and tell your patient, if you are using a cast saw to cut off the cast, that it does not touch the skin. It only vibrates, okay? It only vibrates. It's not going to touch their skin. That can be a very scary time, and understandably so, for the patient. All right, other complications. Delayed union. That's when healing doesn't occur at a normal rate. And non-union is failure of the bone ends to unite, which may require bone grafting. In other words, an additional surgery may have to be done. They may have to go to your ankle or some other part of your body and get some bone and put it at the site where the injury is not healing to enhance the growth or facilitate the healing process somewhat. All right, now signs and symptoms of both of those things would be persistent discomfort and movement. Persistent discomfort and movement. Now, when an extremity has been casted, should your patient say, I feel my bones moving in there? No, they're not supposed to be saying that. If they can feel their bones moving, then the cast is not doing what it's supposed to be doing. All right? Well, let's talk about cast a little bit. We're going to put the ice packs on the sides. Don't put the ice packs on the top, especially in the first 24 hours, because if you put it in the ice pack on top in the first 24 hours, the cast could develop an indentation in it, which would cause a pressure sore underneath, and we don't want that to happen. We're going to use the palms for the first 24 hours, because as you know, in the first 24 hours, the casting material is still wet. So you use your palms, not your fingertips, because we don't want to indent the cast. Now, keep it uncovered and dry. Now, let's think about that. When casting material is wet, it generates what? Heat. It's going to generate heat. So if you've got the area all covered up, can the heat escape? No, you want the heat to be able to escape. I don't want to trap heat next to the skin, especially in a patient like a diabetic with a foot injury. You have to be very, very careful with that type of patient. There are lots of lawsuits out there where a diabetic has come to the ER with an injured foot, and they only focused on the injury and did not talk to the patient enough about their diabetes. When you have a diabetic with a foot injury, you better overcompensate in your teaching and in your documentation, because they are at higher risk for problems, of course. Do not rest cast on hard surface or sharp edge. Cover the cast close to the groin with plastic. We're just trying to keep it clean there. And elevate. That's very important. Another real important thing would be our neurovascular checks. And what do you do first if your patient complains of pain? The first thing you better do is a neurovascular check. Now, if their neurovascular check is okay, can they have their pain medicine? Yeah, they can have their pain medicine if their neurovascular check is okay, but you better be sure and do what in 30 minutes? You better, in really less than 30 minutes, go back and reassess to make sure their pain has been relieved. You've got to make sure their pain has been relieved, because if they are still hurting after pain medicine, what do we have to assume? Compartment syndrome again. Compartment syndrome. Now, do you ever let people stick things down into cast? No. They really want to, because it itches under the cast, but we never, ever, ever allow that. And what they'll do in test questions is they'll give you something really soft, like a Q-tip, to make it sound like that's okay to put down into the cast. No, the rule is nothing goes into the cast. When you've got somebody who's complaining of itching, about the only thing you can do, under a cast I'm talking about the only thing you can do is offer them a cool blow dryer, and that will change the sensation somewhat, okay? Now, traction. Traction decreases muscle spasms, it reduces, and it immobilizes. Now, when I say reduce, what do I mean? Realign the bones. Realign the bones. And if you've ever worked in the ER, you'll see an orthopedic doctor come in sometime and say, come with me, we're going to manually reduce this fracture. Well, what does that mean? That means they're going to take their hands and pop the bones back into place, reducing the fracture. Now, should traction be intermittent or continuous? Continuous, or it's doing no good. It has got to be continuous. Here's a rule you've got to know. Never relieve traction unless you've got a doctor's order. Never relieve traction unless you've got a doctor's order. Because if you relieve traction, what's going to happen to the muscle? It's going to spasm, and further injury can occur then. The weights should hang how? Freely. They shouldn't touch the bed. They shouldn't touch the floor. They shouldn't touch anything at all, okay? So the weight should hang freely. You keep the patient pulled up in bed and centered with good alignment. Well, if I'm the patient that has Buck's traction, that means Buck's traction, as you know, is attached to my leg, and the traction actually hangs off the foot of the bed. So that traction is constantly pulling on your patient, okay? Now, if you've got a patient with a normal body weight, they're able to keep themselves pulled up in bed because their weight will keep them pulled up in bed. But what if you have somebody who's 80 years old that weighs 95 pounds and they have Buck's traction on, constantly pulling on them? Every time you go into the room, where will their weights be? Almost touching the floor, and their head will be in the middle of the bed and they're staring at the ceiling. Okay, now what would you do? How would you handle a situation like this if you had somebody with Buck's traction and it's almost about to touch the floor and the patient's head's in the middle of the bed? Tell your friend how you would handle this situation. Well, what we see a lot of times in the hospital is wrong. What you see in the hospital done sometime is somebody will go in the room, pick the weights up, put them on the foot of the bed, pull the patient up in bed, and then reestablish the traction. Well, they just broke the NCLEX rule. You're never supposed to release the traction. So what you're going to have, and that's what happened when you set the weights on the bed, you relieve the traction altogether, and muscle spasm can occur. So what you've got to do is you've got to get a friend to come help you. And while you're pulling the patient up in bed, somebody needs to be lifting the weights, not relieving the traction. Lifting the weights, because you don't want it to pull on the extremity either, because that could cause further injury as well. And you might as well just plan on going into that patient's room every single hour or 30 minutes and keep them pulled up in bed. Okay? Now, I've seen nurses that got tired of pulling the patient up in the bed, so they just got a sheet and tied the patient to the head of the bed. That is not nice. You do not tie people to the head of the bed or anywhere else. You're not going to get a license like that. And besides, you never want a lot of pressure under the axilla because that can cause brachial nerve damage. Brachial nerve damage. That's why crutches have to be fitted so perfectly, because you don't want the top of the crutch to press up under the arm too much. Crutches are supposed to fit 1 to 2 inches below the axilla. 1 to 2 inches below the axilla. Now, exercise the non-immobilized joints. The rope should move freely and the knots should be secure, and egg crates are okay, and footboards are okay as long as it doesn't interfere with the traction. You see, some traction fits on the foot of the bed. Well, so does a footboard, so you couldn't have both of those things. Now, could I have a footboard with Buck's traction? Could I have a footboard with Buck's traction? No, because where does Buck's traction fit? On the foot of the bed. So you can't have both of those things. Now, what are they using a lot these days to prevent foot drop instead of a footboard? High-top tennis shoes. High-top tennis shoes. But it just looks so funny when you see your 90-year-old patient in the bed with their high-top tennis shoes on, doesn't it? Yes, it looks funny, but it does help prevent foot drop. Now, skin traction. This is when tape or some type of material is stuck to the skin and the weights pull against it. Pull against the skin. Hey, is the skin penetrated? No, the skin is not penetrated. That's why they call it skin traction. Types, Bucks, and Russells, and you've got to do good skin assessments, because could this traction tear off my skin? Yes, it's pulling on my skin, so that's one of your priority assessments would be skin assessments. Now, skeletal traction. This traction is applied directly to the bone with pins or wires, and skeletal traction is used when prolonged traction is needed. I said prolonged traction. Underline the word prolonged. Types, Steinman pins, Crutchfield or Gardner-Well tones, or a halo vest. Now, you must monitor the pin sites and do pin care. Now, when you're doing your pin care, do you have to use sterile technique? Yes, you have to do sterile technique use sterile technique because you've got a pin that's going all the way down into the bone. You don't want to get an infection down into your bone, because now you've got osteomyelitis, and now you've got a patient who's going home on home care getting IV antibiotics at home for the next 3 months trying to get it well. Now, do we remove the crust that forms at the insertion site? Ask your friend. Hey, y'all, what likes to live in crust? Bacteria likes to live in crust. So, yes, we are going to remove the crust that forms at the pin insertion site. Now, you got to think about that. The drainage that's coming out, forming the crust, is the drainage that's bringing the infection away from the bone. So you don't want to leave the crust in place because then drainage can't get out and you're actually trapping infection inside the wound. You want it to come out. Is serous drainage okay? Yes, serous drainage is okay. That's just clear fluid, okay? Now then, let's think about this for a second. You go into the patient's room who has had some type of surgery to their leg and they've got Steinman pins. So you're checking all of their pins. And as you're looking, you see a loose pin lying in the bed. It's falling out. Tell your friend what you would do in this if this should happen to your patient. Okay, are you going to reinsert? I don't think so, because if you just decided you were just going to put it back in and let it fall out on the next nurse, first of all, that was mean. Second of all, you just infected the person, and you just became an orthopedic surgeon just like that, okay? So no, we're not going to reinsert. I heard somebody in the class say cover the hole. All right, there's nothing wrong with that. There's nothing wrong with that because it is an open area. But you've got to remember, what's the purpose of the pin? Stabilization, right? And if the pin is not in place anymore, we do not have stabilization. So the first thing you need to do is stabilize the extremity, and then you get on the call light and get somebody to call the doctor. That's right. Get on the call light, immobilize, and then call the doctor. That's going to be your best answer. Y'all, they're always going to put answers on there like cover the hole or check the vital signs, that sort of thing. But you've always got to look for the best answer to help what just happened. You've got to think about the purpose of the pen. The purpose is stabilization, okay? So if your problem is that the leg is not, the bones are not stable anymore, you've got to select an answer that fixes the problem. That's a good test-taking strategy, is to identify what the problem is and select an answer that most directly attacks the problem. That's a really, really, really good test-taking strategy. All right, now let's look at a total hip replacement. Well, Buck's traction is used frequently pre-op to immobilize. You know, a lot of times, if you've got an 80-year-old patient who fell in the nursing home, they bring them to the hospital and they put Buck's traction on them for 2 weeks till the orthopedic surgeon gets back from their vacation. Or maybe sometimes you've got somebody who's not well nourished and they want to build them up nutritionally prior to going to surgery. So my point is, sometimes they wear the Buck's traction for a while before they actually even go to surgery. Post-op now, neurovascular checks. Firm mattress. Now, here's a basic nursing concept, all right? Now, this is true for any orthopedic injury in the whole wide world. Anytime you have somebody with an orthopedic thing, they need a firm mattress to support the joints. They need a firm mattress to support the joints. That's true for arthritis, orthopedic injuries, whatever. Basic nursing concept. We're going to monitor the drains if they have any, all right? They don't always have drains. Sometimes they do. But if they do, the purpose of the drain is to get that fluid out. And you want to make sure it's functioning properly, because if the fluid is not able to come out, a compartment syndrome, or at the very minimum, poor perfusion is going to occur. And overbed trapeze is good if they'll use it, because it's going to help build upper body strength. Help build upper body strength, and that's what we need. Now, that's a good thing, because when you have somebody post-op hip and they begin to ambulate, many times they use a walker. And to use a walker, you've got to have a little bit of upper body strength. That statement, y'all, is true for the use of any assistive device, whether it's crutches, cane, walker. With any assist device, you have to have some degree of upper body strength, and most women don't have a whole lot of upper body strength. So the overbed trapeze is really good for them to use. It'll also help them with things like getting on the bedpan, pulling themselves up in bed, that sort of thing. Positioning, neutral rotation. That means toes pointed to the ceiling. Toes pointed to the ceiling. Now look at my hand and pretend it's my foot. Okay? See, right now my toes are pointed to the ceiling. If for some reason my foot turns inwardly too much or outwardly, what is it doing to my joint up here? It's rotating the joint. That is bad post-op, because could that make my hip dislocate? Yes, that's what we're scared of. So that's why we want the toes pointed to the ceiling. We're trying to prevent all that rotation. Limit flexion. Flexion is bad, bad, bad here, y'all, because what will it make your hip do? Pop out, dislocate. Flexion is bad. We want extension. Extension is the good thing. Now, while I'm standing straight up and down, is my hip flexed or extended? Extended. If I bend over to tie my shoe, what did I just do to my joint? I flexed it. When somebody's lying flat in the bed, they are extended. And when you come in the room and you start raising their head to give them their lunch tray or whatever, they're flexing. So you've got to be very, very, very careful. Another time is when the patient's getting on the bedpan. The first thing they want to do is pull both of their legs up. Always keep one hand on the affected side, like on their knee, reminding them to keep that leg and hip straight, because if it flexes really close after surgery, it could pop out. So flexion is bad. Do you want abduction or adduction? The first one, which means what? Legs apart. All right? We want the legs apart. That's why they have abductor pillows, to keep the legs apart. Here's the deal. They've gotten that new hip joint in place, and they want to keep it up in that socket as long as they can, because the longer they can keep it up into the acetabulum, the socket, the greater the chance it's going to stay there and not dislocate. So that's why we have an abductor pillow. Now, what exercise can the patient do while still confined to bed? Isometrics. Isometrics. Now, when I say isometrics, I mean things like squeezing the quads, squeezing the glutes, all right? That's real important, to squeeze those muscles, all right? Now, when you squeeze your muscles, yes, you are maintaining some muscle tone. That's important. You're maintaining muscle tone, but also, anytime we squeeze muscles, what just happened to venous return? Increased venous return. That's very important for preventing a DVT. We're increasing venous return, keeping that we're preventing stasis of blood. We don't want a DVT. All right. Now, what is the purpose of the trochanter roll? To prevent external rotation. To prevent external rotation. Remember, we don't want rotation, because we said that could make your hip pop out. And all a trochanter roll is when you take a towel or a blanket and roll it up and place it along the greater trochanter. That prevents external rotation. It prevents the foot from flipping outwardly, all right? And you also should document the presence of the trochanter roll in your nurse's notes. No weight bearing until ordered by the doctor. I know that some of you had somebody one day that had a total hip and they got them out of the bed that day. That's fine. That's great. But it depends on the doctor's order. So that's why it says no weight bearing until the doctor orders it. Some doctors want you to get up that day and try to put a little pressure on it. Some doctors will order what is called touchdown exercises, which means they want you to sit on the side of the bed and touch down with your feet. Okay, so different doctors want different things. So no weight bearing until ordered by the doctor. Avoid crossing legs. Avoid bending over. It's going to dislocate. We've got to be careful with that. And is it okay to sleep on the operated side? No, I'd rather not. Not until the doctor says so. When the doctor says it's okay to sleep on the operative side, then that's when we'll let the patient do that. We really don't want more pressure over there, now do we? We're trying to protect that hip. Is hydration important with this patient? Of course, because you've got somebody who's really immobile, aren't they? A lot more sedentary than they used to be anyway. So we're worried about a DVT. We're worried about pneumonia. So that's why we're going to be encouraging lots of fluids. And stresses to the new hip joint should be minimal in the first 3 to 6 months. Is it okay to give pain meds in the operative hip? Let's not do that. I think they have enough trauma over there, don't you? Yes. Complications. Well, we've mentioned dislocation several times, and as you know, that can lead to circulatory and nerve damage. Circulatory and nerve damage. Signs and symptoms. Shortening of the leg, abnormal rotation, can't move the extremity, and pain. Put a star by that one. Because this is typically somebody who's been doing fine, and then something today is just not right. Maybe their extremity doesn't look right. The patient's complaining of more discomfort than they have been. We're going to assume the worst. Now, other complications, infection. That's why the doctor always puts them on prophylactic antibiotics. That's why we've got to get rid of the Foley catheter and suction and drains if they have any of that stuff. Because Foley and the Foley and the suction and the drains and all of those things harbor bacteria, don't they? Yes, we want to get rid of those. Now, let me ask you a question. Does this patient have a foreign body in their body now? Yes, they have a foreign body. Anytime a foreign body is in your body, and you like an artificial heart valve, for instance, if you get an infection, where is the first place that bacteria wants to go to? To the foreign body, whether it's my hip or my heart valve. And this infection can cause so much damage that the surgery has to be completely redone again. That's why when you have, this is a basic nursing concept. Anytime you have somebody with a foreign body in their body, they always take prophylactic antibiotics before any invasive procedure. Like going to the dentist is the thing we're most familiar with. Or maybe just having a mole removed. Or maybe you're going to have a gastroscopy or a bronchoscopy. Any type of procedure like that. Avascular necrosis is another complication. Well, the name says it all. The area is dying because there is no what? Blood supply. The area is dying because there's no blood supply. And there's just not a whole lot you and I can do to control that. Sometimes it happens, sometimes it doesn't happen. And immobility problems, and you know what those are. Now, the best exercise for this person is going to be walking. Walking is good for this person when the doctor says it's okay, that is. Now, my second favorite exercise is swimming. Swimming. But y'all, what if you've got a 90-year-old lady who's not going to go walking and she's not going to go swimming? What can she do? Rock in a rocking chair. Rock in a rocking chair. Now, here's the deal with that. If she wants to rock very much, what is she going to have to do every time? She's going to have to press off the floor with her feet. Press. And, you know, you're not going to build up big quads doing that. I know. But we've got some movement. We're maintaining some muscle tone. So it's a good thing. It's better than nothing. Avoid flexion. Now look at all those things that we have listed there for you. We're really emphasizing with hip people how bad flexion is. We want to avoid flexion because we've already said it can make your hip pop out. And then the last thing we have here is the CPM, which stands for continuous passive motion. Now that's used mainly with knee replacements, but it's most of the time physical therapy does all the setting up of this. But if it's equipment in our patient's room, we're still responsible for it too. And one of the most important things you have to check the CPM for is the angle of flexion it is set on. The angle of flexion that it's set on, because if they flex them too much, it can ruin their surgery, whether it's a knee or a hip or whatever. And also, you've got to administer pain medication with the use of this CPM because this is painful. Now we have amputations. Amputations are performed at the most distal point that will heal, and the doctor tries to preserve the knee and elbow if they can, because if they can preserve my knee, when I get my prosthesis and I begin to ambulate one day, my gait will appear more normal if I have my knee. If they can, they'll preserve my elbow joint, because that way I'll have better use of my arm and my prosthesis. So they try to preserve those joints if they can. Now, post-op, what are we going to keep at the bedside? A tourniquet in case of massive hemorrhage. A tourniquet in case of massive hemorrhage. Now, some books will say in a shaded box out to the side, clinical alert, never tie a bleeding stump with a tourniquet because it can cause too much soft tissue trauma. Now think about that. If your stump is hemorrhaging, would the NCLEX people rather us stop the hemorrhage or preserve the tissue? They'd rather you stop the bleeding. It's the most important thing. That's much more important. I can deal with soft tissue damage later, okay? NCLEX is about keeping people alive. Elevate on a pillow for the first 24 hours. Then how do we elevate? By elevating the foot of the bed. By elevating the foot of the bed. Now, in the real world, the doctor's going to let us keep the residual limb, as it's sometimes called, up on a pillow the whole time they're there. But we're scared of that answer on NCLEX, because if you keep the residual limb, the stump, up on a pillow the whole time, that's promoting a hip contracture. Promoting a hip contracture, and that's bad. I'm scared of that. All right, prevent hip and knee contractures. How? There's one word that I want to hear, okay? Extension. Extension. That's the word that will prevent a contracture. All right, now look at my arm for a second. When my arm is out like this, am I flexed or extended? I'm extended. When I'm doing this, I am flexing. We want extension of the extremity, okay? Now, what if I have a below-the-knee amputation, okay? If you have a below-the-knee amputation, you've got to worry about me forming a contracture in two different places, my knee and my hip, okay? Because we have two joints left in that extremity, don't we? So, what would be a good position that we could encourage this patient to get into several times a day that would force their hip and their knee to extend? Ask your friend. And the answer is prone. Put them on their stomach. Now, the deal with this is you just don't see a whole lot of people in the hospital on their stomach, do you? No. But it's a great position for extending the hip and the knee. Now, phantom pain. First of all, I got to ask you something. Is it real? It's real to the patient, and that's all that matters. Even though it's called phantom pain, it's real to the patient. We should never, ever, ever be judgmental of people's pain, right? Never be judgmental of people's pain. Now, what is the first intervention to decrease phantom pain? Well, obviously, it's diversional activity, right? Yes, diversional activity. But are they going to get pain medicine too? Yes, we're going to give pain medicine to this patient, but remember on NCLEX, we want to try the least invasive things first, like diversional activity. We want to stay away from medicines as long as we can. Show the NCLEX people that you're going to at least try some diversional activity before going straight to the pain shot, okay? Least invasive first. Now, phantom pain is seen more with above-the-knee amputations, and it usually subsides in 3 months. In some people, it never goes away. They always have the feeling that they have kept that digit that was amputated, or that extremity, whatever it was. Now, you will see our NCLEX tip there. With pain, use other things first prior to the pill. The definition of pain is what the patient says it is, and I always assess the client's pain by having them rate their pain on a pain scale, like the pain scale of 1 to 10. Now, why is limb shaping so important? For the prosthesis. For the prosthesis. Now, how do you want the stump to be shaped at the end? Like a cone. Like a cone. That just means it's rounded and smaller at the end. Rounded and smaller at the end. Cone shape. That way it's going to fit down into the prosthesis better. Now, what is worn under the prosthesis? A limb sock. A limb sock. Now, when I come back from surgery after I've had my amputation, I'm going to have a really, really tight compression bandage on my residual limb. Now, immediately post-op, what's the purpose of the really tight compression bandage on the residual limb? To control bleeding, decrease edema. Control bleeding and decrease edema. But let's say that 2 weeks later, I have on the same exact type of garment. I have still a tight, stretchy thing on that they're calling a limb sock. Well, 2 weeks later, the purpose is not to control bleeding and edema. The 2 weeks later, the purpose is shaping of the stump. Shaping of the stump. All right. Now, why is it important to strengthen the upper body? Well, we mentioned this earlier. When you have someone who's going to ambulate with assistive devices, which I'm sure this person will be using assistive devices, you have to have some type of upper body strength, right? Yes, we want some upper body strength. Is it okay to bear weight on a new stump or prosthesis? No, not until it's well healed. Not until it's well healed. And is it okay to massage the stump if you should become bored at work one day? Well, think about that. Normally, when you and I think about massaging extremities, we worry that we're going to massage and dislodge a clot, and now our patient's going to have a pulmonary embolus or something like that. Well, that's different. That patient has their entire extremity. In this scenario, massage is good. Massage is a good thing because it promotes circulation and decreases tenderness. Promotes circulation and decreases tenderness. So it's a good thing here. Now then, how do I teach a patient to toughen the stump? Well, first of all, why do I care if the stump is tough? For the prosthesis. For the prosthesis. So that's why we've got to teach them this. Press into a soft pillow. Press into a soft pillow, then a firm pillow, then the bed, then the chair. And you're saying to your friend right now, I've never seen this done before. Well, I haven't either, but it'll be right on NCLEX, and that's all we're worried about. Now, the reason you and I typically don't see that done is because that's something that's done outside of the hospital on an outpatient basis, okay? Now, before we close on this orthopedic section, tell your friend how to walk with a walker. Well, what the patient's supposed to do is they're supposed to pick the walker up, put it in front of them a little bit, and then walk into the walker, aren't they? Yeah, they're supposed to pick it up, put it in front, and then walk into the walker. People don't do that in the nursing home now, do they? No. Sometimes they'll pick up their walker and then walk over here and talk to their friend and sit down and rest on it, all right? Pick it up and then carry it over here somewhere. They're not supposed to do that. Or sometimes you see the galloping walker coming down the hall, all right? And then sometimes you have the slider. The slider. Well, if you've got somebody who's a slider and they've got rubber caps on the bottom of their walker, that's a safety issue, isn't it? Yeah, you got to take the rubber caps off if they're a slider and put tennis balls on the end of the legs so it'll slide more easily. All right? Now, crutches for a second. I've already told you that crutches are not supposed to fit under your arm really tightly. They have to be measured. You're not supposed to go borrow your friend's crutches if you have an injury. They have to be custom fitted for you, okay, because we don't want brachial nerve damage, as you know. Now, here's a good rule of thumb for crutches when you're walking up and down stairs. When you're walking up and down stairs, this is what you need to write down. Up with the good and down with the bad. I'm talking about the good leg and the bad leg. Up with the good, down with the bad. And remember, when someone's had a stroke and they're using a cane, they need to use the cane on the side that they're strongest, all right? Not on the affected side, of course, all right? So if I've had a right-sided stroke, the left side of my body is going to be weaker, so I'm going to hold the cane with my right hand. All right, that's enough on the orthopedic section.